So the first thing is, I think, just to realize that it's a really individualized decision. I think you have a lot of, I guess, a body of literature to look at, but unfortunately, it's not that it's going to provide, I think, a clear and unequivocal guidance in all cases. I think you look at basically the patient, their age, their performance status, their IMDC risk criteria. You look at the disease, perhaps the histology, disease burden, the distribution of that disease. And then, you integrate all of that. I think as a broad rule, one should consider it in every patient as an upfront thing. And I think that you then have to kind of disqualify people or disqualify for the time being based on what we know from the literature to be beneficial. So I think what we know is that if you have multiple IMDC criteria, that's probably harmful. We probably know also that if you have systemic disease that requires urgent treatment and the local primary is not causing too many problems right now, that is also probably harmful to do an upfront cytoreductive. I think that those are the two biggest situations where we clearly probably see it being not a good idea. I think in the remaining kind of patients, we really have to consider the overall plan. It's never kind of a bad idea to consider upfront systemic therapy and then deferring it down the line should it be kind of unequivocal or there be a lack of equipoise in it being beneficial. And so I think that's always a reasonable approach. And these are great cases to bring to a multidisciplinary setting, to have a kind of tumor board discussion about, to incorporate shared decision making and all of the kind of patient preference side of things, given the clear lack of an understanding for, I guess, the index patient.